So good afternoon, everybody, and welcome to our sixth clinical learning event of the Modern Ward Round Collaborative. Really great to be here today. So my name's Claire Sanders. I'm an improvement manager with the Emergency Care Improvement Support Team. And as you know, the Modern Ward Round Collaborative is a joint piece of work delivered by the Royal College of Physicians, Royal College of Nursing and the Emergency Care Improvement Support Team. And I'm really delighted to say that today's speaker is Professor Matthew Cooke. But before I properly introduce Matthew, just some brief introductions to some of the clinical reference group that we might have on the call today. So if we could ask everybody else to put their cameras off, but if we have clinical reference group colleagues on the call, if you could just pop your cameras on, please, and just say a quick hello, that would be really good. And then we've got Lynn from the Patient Carer Network as well. Hello. Thanks, Lynn. Andrew.
Hi there. Hi, everyone.
David.
I am a Chief Pharmacist from Northumbria FT.
Hi, David. And of course, we've got Matthew. That's brilliant. So during Matthew's presentation, I know there's going to be lots of thoughts, reflections, questions. So do make real use of the chat so that we can have some really good debate afterwards and get your questions ready. So I'd like to just introduce Matthew then. So Matthew is currently a colleague of mine at the moment, so it's no surprise to me that his topic today is about disruptive thinking. Matthew is Professor of Emergency Medicine at Warwick Medical School and Heart of England NHS Trust, and he's held several he's held several national roles, including the National Clinical Director for Emergency Care in England. So Matthew continues to work in a number of improvement roles across the NHS, as well as being the Chief Clinical Officer for Capgemini. So thank you, Matthew, for being with us today, and it's over to you. Thank you. Oh, I think you might be on mute there.
It's always that wonderful thing when it works so well in the practice, and then
we've just done a practice.
Hopefully you can now see my screen.
Okay, something's happened. Yes, thank you.
Thank you for inviting me. When I was invited, I did feel a bit of a fraud. You know, I'm an emergency physician. I don't do ward rounds, but of course. I actually did try to retire 2 years ago. Never a good time to retire just before a pandemic, so I found myself back in a different role. So after 25 years of not doing a ward round, I had to do some ward rounds last year, and therefore I looked at them and in a different perspective. And as Claire said, the aim of this talk is for me to be disruptive in my thinking. What do we mean by this? We're all familiar with some companies, such as the ones you can see on the screen, that have disrupted their markets. You know, many of us, you know, I can see a few friends, and therefore I know their ages, can remember the days when we had 4 channels on the TV, and we had to wait a week to see the next episode. And Netflix completely disrupted that. You know, the concept of a taxi company delivering your food, that was for the very rich in the past, and now it is common, let alone everything we can do on our mobile phone, which, you know, that device that has a bigger computing capacity than Apollo 11 did when it landed on the moon. So people thought very differently to get there. They didn't just do small incremental improvements. And we've got some examples in health. Some of them were forced upon us. So Teams, obviously, over the last 18 months has become an everyday part of our life, whereas most people in healthcare didn't use it. The Libra device has revolutionised how diabetics manage themselves, and has enabled many diabetics to manage their own disease. Because, of course, it was Dr. Rochford who invited me, I had to put that top right-hand one. You know, I can remember when we didn't know about these bacteria causing ulceration of the stomach, and the people who first revealed these ideas were completely mocked by the medical profession for their completely different thinking. So all I would say is, if you think what I think is mad, there are two possibilities. One is that I'm just ahead of you, the other is that I am completely mad. So the history of the ward round. When I first did a ward round as a medical student, and you know, I know it'll stagger you to know that was in the 1970s. We met the boss at the front door of the hospital at the Queen Elizabeth in Birmingham, and we walked up to the ward in order. So as the medical student, you were right at the back of that long trail. Yeah, truly James Robinson Justice style. And then, you know, as a houseman, I had the twice weekly ward round that I spent a day preparing everything and getting it ready so that the information was immediately available in the notes to the consultant. And, you know, it was a medical ward round, so we'd spend 6 hours going round these patients. And that was what really convinced me to go into emergency medicine was, and the consultant did say to me many years later, he knew I'd be an emergency physician because I fell to sleep at about 3 hours. And more recently, then we've got the daily board round and you know, the daily senior round. So things have changed, but the underlying principle, I would argue, is much the same as it was in the 1970s. You know, not to criticise, because I'm sure some of you were intimately involved in this. But if you read the modern ward rounds, this is about taking what we've got and doing small improvements to make it better, rather than real disruptive thinking. So what I hope is to provoke you now into thinking, could we do it completely differently? So what has changed in those nearly 40 years? We do the ward rounds more often. We do it in a different way. We do smaller ward rounds. But my observations over the last 2 years that surprised me, and I guess those of you who do ward rounds, it's no surprise at all. I was amazed that there wasn't always a nurse on the ward round as I went round. And sometimes it was multidisciplinary, sometimes it wasn't. We didn't seem to be able to coordinate ourselves so that we could all be in one place at the same time. But it was also no longer the big event that was prepared for. You know, now perhaps I'm just being, you know, a grumpy old git, but it quite surprised me that we were spending a long time on the ward round chasing the results, the stuff that I used to do as a houseman the morning before the afternoon ward round. But the good news was we did have a computer on wheels that we could take round with us and look up the results. Although, of course, you immediately think computer on wheels, the only place you see those is in hospitals. Everybody else has something they can hold in their hand. The decisions that were being made, you know, did they really always need a consultant? It felt to me as if there were a lot of decisions that, you know, could have been planned. And my interest in technology, as you heard, I spent 2 days a week working for a technology company. I was amazed how little technology was in use. So what is the function of the ward round? So, you know, in order to redesign it and think radically, we've got to think, well, what do we want to achieve? Is it to make every decision about that patient? Is it to validate the decisions that have already been made by a junior doctor? I would argue senior clinical input is the key. Is it a stock take? Because actually, if we do it every day, it's less of a stock take than it was when it was twice a week, when you could just take a breath and say, is everything heading in the direction we think? If you do that too often, you don't notice change. Is it about teaching? Is it about support for the staff? Is it about communicating with the patient? This is their one opportunity to speak to the senior clinician. And until you've worked out which of those functions you want to achieve, how can you say whether a ward round is working correctly? So my first thought was, well, why do we actually bother with ward rounds at all? Is it just tradition? Why don't we make decisions when they're needed rather than at these set times? As an emergency physician, I am in the ED. When a decision needs to be made, it is made there and then. It doesn't wait for me to go round the cubicles. And I know this is deliberately provocative because, you know, the physicians in the audience are going to point out very rapidly, you know, that's all I do. You know, I don't have to go off and do a clinic. I don't have to go off and do endoscopy. But is there a way that we could bring that decision closer to the time when it's needed? Devolving responsibility is the traditional way of doing that. The ward doctor makes the decision. But are there other ways? And one of the things I wanted to talk is about what we call the CRM process. And CRM processes, these are called customer relationship management processes that are used widely. My job in Capgemini was originally to look at what we did in other sectors and say, could we apply it to health? So if you have a crash or your car breaks down and you take it into the garage, before you arrive, they've got the whole thing planned out. Even though it's going to vary according to what's the matter with the car, there is a plan. And some of those steps you can jump past because it's not applicable. Some of them will be much bigger on occasions, but there is this path used that you can see in the diagram. And you predict the journey and you plan for the vast majority. So it may be instead of a car, we put there an elderly person with pneumonia, and we can predict the steps in the journey, and we can say if it's going well, they can go home at such and such a date, but between then we can say when we need investigations, when we would expect the temperature to be settling, etc. And in the car industry, you then look and say, well, in that journey, what can we automate? So yeah, we can automate that you need a blood test on day 3 of your stay for certain conditions, and you know, and nobody has to write out the form. It just appears on the work list of the phlebotomist at that time, and we can get rid of the request from the ward round for tests in a large number. And this is all about standardizing it so that the ward round becomes the managing of exceptions rather than the managing of the everyday. And we know that exceptions can be good or bad. You know, that varying by every patient will mean that we're not doing the right treatment for some, but we're doing better for others. So could we have a system that the patient gets to a certain stage and it sends you an alert on your phone saying, Mrs. So-and-so who's had the GI bleed, her hemoglobin's now 6. Can I send her home? And you just tap approve, and you don't have to wait to go onto the ward to do that. You know, so all the actions being automated, being digitalized, so that it can all be done remotely. But we probably didn't come into medicine to do everything remotely, despite the fact that we're all now sitting in our separate offices, and we've learned to do a lot more remotely. If we take away the ward round, what about that bit about being a human? You know, as a patient myself recently, I had some quite severe eye problems, and you know, potentially was going to be blind, and the pre-op visit from the surgeon and him just putting his hand on my shoulder and saying, "We'll sort this, you'll get your vision back, Matthew," was way the most important treatment secondary to the operation. Yeah, if I'd had a text saying "don't worry," it wouldn't have quite been the same. You know, how do we make sure if we automate and eliminate a lot of these processes, we still have that empathy and that compassion into the service? So my challenge is, how do we get the decision at the earliest possible time and not wait for the ward round? How do we make sure we involve the patients and carers? I haven't talked about that because CRM systems also mean, as a customer, you can see where you know, your car is in that process. You know, we're all used to the fact that we can look up on Amazon and see where the parcel is, but we can't look and see where we are on our patient journey. You know, what are we waiting for at the moment? How can we use the technology to use this? And my big challenge, having spent a life of PDSA cycles, is there is a certain stage when, you know, PDSA cycles have to be replaced by a complete redesign. in order to get that disruptive thinking. Should we be adopting that approach with the ward round rather than just tinkering at the edges and polishing up something that can never really achieve the change? So I hope I've irritated some of you. I hope I provoked you, and what I'm really keen to hear on here and discuss with you now is what would be the really disruptive change you would put in to create the modern ward round. So I'll hand back to you, Claire, to chair the debate.
Wow, thank you, Matthew. That really has, I think, put the cat amongst the pigeons. Fantastic to hear that. There's some comments in the chat box already. Andrew started us off by talking about that real challenge about the much quicker turnaround of patients now compared to 5 and 10 years ago. And I suppose I would want to ask the question, so how quickly were those patients turned around before, Andrew? That's not something that in my 30-year career I remember it being much faster or much slower. Do you want to add into that?
Yeah, sorry, I've already got into a sort of a chat room debate with a colleague. So I mean, when I was a house officer, admittedly more than 20 years ago, you know, people waited 6 weeks for an inpatient angiogram on CCU. And, you know, there was, Matthew, you know, the groundbreaking work you did about emergency associated with length of stay within an emergency department, and the clinical rationale and importance of the 4-hour target that didn't exist when I was growing up as a junior doctor. And so the ward round, you know, the post-take ward round took 2 days, and you know, patients were everywhere.
Wow.
The point, I guess, I was trying to respond to Matthew's comment about the stock take aspect of a ward round. And actually, although a lot of wards will turn over 1 or 2 patients every day, but they will also accept other patients. So there'll be step downs from ITU, there'll be transfers from other wards necessitated for infection control and that kind of stuff. And added to that is the complexity of the challenge of continuity of care, where the workforce today will not be the same junior doctor workforce, the same nursing workforce. So it was just to kind of highlight some of the complexities in relation to the comments for stock taking.
And I think it's interesting, Andrew, you know, some of the comments in the chat now about, you know, David's talking about who makes the decision to discharge. And part of me says, well, you know, as a houseman in the 80s, you know, I would discharge people, but actually looking back on that, I think that was a bit scary. You know, whether I discharged the correct ones, I'm not sure. I think it would have been better if somebody more senior had been involved. But then when it got busy in winter, if you looked at the date of discharge, from the firm I was on was amazing how the number of discharges went up on the day you were on take. So we kept people in to make sure that we had beds on our take in those days. So yeah, there were a lot of hidden factors in that decision making. If it was convenient, too junior a person made it. But I must admit, I was surprised last year as to how many decisions had to be made by a senior doctor that I perhaps would have expected to have been made by somebody who was based on the ward and therefore could be done immediately.
Absolutely. Helen's just echoed that point really about empowering and enabling senior nurses, ACPs, to do some of this. And I think it's something that we struggle to see at ward level. And I wonder what the barriers are to actually making that happen.
And the whole concept of, you know, criteria-based discharge. Just before I left ECIST, it was just coming in, and I have to say, yeah, I probably didn't make any friends by my reactions to it, because there was so many rules coming in rather than, you know, allied health professionals, nurses being able to use their common sense, and even just, you know, the rules that were put behind. If I said they can go home and if their hemoglobin's above X, oh, you know, that couldn't just be done by the band 5 nurse. So, you know, it seemed to come down to somewhere in the system there wasn't trust. But there was the trust. If you're on the ward, there was the trust between the consultant and the staff he was delegating it to. But within the organisation, they didn't believe that trust existed.
I think it's the typical scenario of managing risk, isn't it, as well? I've seen that today on a ward. A patient couldn't go home for their package of care because the package of care wasn't ready. So they were going towards the least worst option and actually transferring the patient into a bed base, a community bed base, for a period of time to wait for that package. But actually that bed base wouldn't be prepared to take the patient until they'd had a set of bloods done. But actually the patient had been medically fit for the last 14 days and did not therefore need any blood. So we're medicalising also the decisions that we're making in terms of managing the patient across the system. And that's an integrated system, not just, you know, going from one organisation to another. So I think it's absolutely there, isn't it, Matthew? Andrew, you've got your hand up.
Yeah, I'm sorry, apologies everyone, I don't mean to monopolise it, but while I got Matthew on the call, it's just, I wondered if there's, so linking what we've just been talking about, sort of senior decision making and the role of the consultant on the ward, whether there's anything that we could learn or take from industry, because I'm cognizant that whilst we may make a decision, I may make a decision about discharging a patient today, I don't always do that in knowledge of what the necessary steps are, what is needed to affect that from a workload perspective. This is, you know, so I don't know the other pressures on the nursing team or the therapy team, you know, the transport team, the home situation. Do you see what I mean? So we rely on a decision, but affecting that is not a consultant level. And I wonder if there's anything from industry that we could learn from.
Well, so I suppose what those CRM systems would do is you would put in home if, it would then log that and you know, it may inform you that those criteria, but it would then also look at the next steps and say there's a problem in this step. So, you know, just on that, like on Amazon, you order the product and it then tells you it's not going to be available for a week. A CRM system would say, you said the patient will be ready for discharge with the blood results. The system knows that blood result will usually become available in X number of hours, but in X number of hours it also knows that, you know, the therapist who then needs to see the person won't be available, so it would then highlight in advance. So CRM systems, the basic principle behind them is they save time because they're predicting what's going to happen next and they're checking whether it will happen at that time, rather than what we do is we wait until it happens, or doesn't, or even worse, we wait till it hasn't happened for a few hours and then investigate. So it's all about predicting.
So ironically, just to come back on that, a CRM system will be able to predict our readmissions, and that links, I know there's some chat about that at the moment, technically, potentially.
Yes, and I think, as Josie said in the chat, you know, the cultural thing about failure. You know, if you're one of the more fun things I did when looking at other sectors was nip down the M42 from the M40 from where I live, and spend a day with Mercedes Formula One, and they plan in a normal Grand Prix season that each of their drivers will spin off and not finish twice a year. That's part of the plan, because if they have a plan that says we will never spin off, the drivers will operate at 95% capacity. If they have a plan where they know they'll spin off, they'll operate at 98, accepting that occasionally they'll go over 100% and not finish. So, you know, we need the same. We need to accept that, you know, we will do this number of discharges and a certain percentage will end up coming back. You know, not because of, you know, bad care, but that's the human nature and, you know, the variation in the system. But the system will be able to tell you, it may not be able to tell you this patient will come back, but it'll tell you there is a risk of 90%. So the patient can be, and their carers can be better informed.
Absolutely, absolutely.
I was one of the things that I was, when I was preparing this talk, that suddenly came across my head was this, you know, automation depersonalizes. And I'd just be really interested from, to have a comment from Lynn about, how much, and it may vary from person to person, younger generation, don't like talking to people, they'll prefer talking to their phones perhaps, other people, but I'd be interested in Lynn's perspective of that automation and the risk of depersonalization.
Yes, thanks very much, Matthew. I jotted down a few things whilst you were speaking, which was really interesting, I found, thank you. The first thing that resonated for me was that when the work started on the Modern Ward Rounds report, John, Dean and Nikki came to a patient and carer network workshop, and we had a roundtable discussion about ward rounds, and one of the things that was actually said at the time was, are ward rounds really necessary in this day and age? So, I think it's interesting that certainly some patients query why ward rounds are really necessary. But on the other hand, I do think that for a lot of patients and their families, ward rounds are kind of a given. They're known as an opportunity. That's when we'll be able to talk to X, Y and Z, and we'll be able to find out what's going to, or hopefully we're going to find out what's going to happen, and importantly, when we're likely to go home or to have our relative back home. So I think there's also the fact that they are obviously a set piece for communication, and whilst I'm, I think your slide on the fact that people aren't machines, I was actually just about to make that point. People aren't machines. It's all about recognizing the patient as a human, and your example, your personal example, I think was very powerful there, Matthew. Very often, I think, and I speak personally myself as well, it's that sort of personal reassurance, that demonstration of empathy and compassion, which actually does you an awful lot of good. And so I think there's a really fine balance to be struck here. And if I could just sort of go on to the conversation in the chat about discharge as well, is that to do with clinical leadership? Is that to do with, this reluctance that some people have? And I can understand that reluctance and the being risk averse, but is it about not having very clear parameters set by clinical leaders?
And I suppose one just trying to be even more provocative, and I agree, in the present situation, the ward round is a very good focus for patients, families, carers to have the opportunity to speak to the consultant. But what would be disruptive is, why can't that carer WhatsApp the consultant and arrange a time to see them? Do it. It's still slightly paternalistic of us in the profession to say we'll only see you on the ward round.
Yeah, absolutely. And there's something for me as well about, and I was part of the group that worked on this. There were two of us from the Patient and Carer Network in the sort of task group. There's something for me about, I think your challenge about, turning the whole thing upside down is a very valid and important one. But there's something for me about, change being evolutionary, not revolutionary. But I noticed what Andrew's saying in the chat about, he wonders whether we haven't been disruptive enough around ward rounds post-COVID, because I think one of the things that the pandemic has done is perhaps forced and perhaps opened up that opportunity to turn things completely upside down and on their heads. And maybe there should be more of that going on. I don't know, but yeah, I quite acknowledge that everybody's exhausted.
Experience in other sectors is very clear. People who know me will know, I like to have the latest gadget. I like to do something different. There are others who absolutely hate that and prefer familiarity. And that's one of the challenges, the whole concept of early adopters. I'm the early adopter. laggards aren't necessarily, just stick in the mud. It's their comfort zone.
Sure. Yeah.
And big change isn't their way of doing things. So how do we respond to those different personalities within professions as well? Some things are forced on us, by retail companies or whoever. My wife was one of those who signed the protest about this new Sainsbury's in our village. We just like the village shops. Of course, within 3 months, we're regularly using Sainsbury's, etc. So it was forced upon us as a village, and now we all love it. And how do we know which of the things that we need to force and people will love later, and which of the things we'll force and regret? I wish I knew the answer.
Really good point. I think it's really interesting to think about ward rounds, and actually that's not the only place where empathy and compassion takes place. Do you know what I mean? So actually, what could we do differently to be far more person-centred than actually doing that on a ward round, which is, a regular occurrence? Eddie, did you want to come in at that point?
Yeah, thank you very much. I really wanted to pick up the theme of empathy, because I'm all in favour of disruptive technology, although I'd actually link it to what Lynn's just said. It's actually not new, is it? It is evolution itself. I mean, the invention of the wheel, the discovery of fire, it's all disruptive technology. Allegedly, the discovery of fire allowed our sort of ancestors to be able to eat protein more easily, and therefore allegedly our jaws didn't need to be as big, allowing our brains to grow, etc. I think mine must have missed out on a few of those evolutionary steps. But my point is about ownership and risk management, because one of the things I think is really important for patients, however you organise a ward round, and it is about risk management, is for people to take ownership, responsibility for it. And we all know that no matter how good the process is in a customer relations management organisation, when something goes wrong, trying to speak to a human being is virtually impossible. And similarly, when my elderly father was a patient on a busy acute ward, although his care overall was very good, actually pinning down personal responsibility was actually quite difficult. And although I know my way around the system, I didn't mind whether it was a senior doctor or whether it was a senior nurse, but I just wanted one individual whom I could trust would actually be able to deal with the issues. So it comes back to the empathy bit, the hand on the shoulder. This is going to be okay, Matthew. I wanted somebody to put a hand on the shoulder saying, Ed, don't worry, we're sorting your dad out. And I think finding the blend between those 2 points is really critical. And part of that is the ability on a ward round for patients or their families to be able to be satisfied around that personal responsibility.
And I totally agree. And interestingly, I heard somebody from one of the very big technology providers in the UK, when they were commenting about CRM, saying the difference between a good and a bad CRM is the exit route. 90% of the time it goes right, but if it doesn't go right, how quickly does it recognise that? And usually, how quickly does it therefore pass it to a human? The percentages may be different in healthcare. It may be a larger percentage that need a quick exit to a human out of an automated system, I think.
I agree entirely. Thank you.
Thanks, Eddie. I'd like to bring in Victoria, please, if I may. Victoria's made a couple of comments in the box there around care being system-wide, which includes the patient and their family. And one of the first things I learned in my training was that the patient was part of the MDT, and that's really left me. So I don't know, Victoria, do you want to add anything into those comments?
Sure, thank you guys. I find this really fascinating. So I'm also involved in the ECIST board round piece as well. So both of these really dovetail beautifully together. Some of the things that we come across in our board rounds piece is around people not wanting to discharge their patients early. They are very risk adverse. They worry about what's going to happen to them when they leave our building. And I think there's definitely something about actually understanding that this is system-wide care, that actually there are agencies, there are professionals in the community that can actually support these patients and their families when they leave our building. And I guess making sure that we understand what that care can be, but also what care the families can provide, and actually having that ownership. You know, we've got to remember healthcare is a partnership, isn't it? It's not all about us as care deliverers. We actually have to, you know, you have to have a responsibility as a patient ourselves to make sure that we do maintain our own care as much as possible, and by extension our family are kind of responsible for that as well. So I think this seeing patients, their care journey ends when they leave the hospital setting. We need to almost get out of that mind frame, think outside the box and fully understand what support is out there. Because I think, you know, one of the people in the chat said, once you understand what care can be provided, it gives you a lot more clarity and a lot more trust in actually allowing your patients to be released from hospital, if you like.
And I think we're seeing really good examples of that, aren't we? I mean, you mentioned Helen's comment from Gloucester, but and similarly, I know the situation at South Warwickshire, where that relationship between the community services and the hospital, so the hospital feel confident in discharging because they know what is on offer and they know that a safety net is reliable in the community. So I think that's a really important thing, is, you know, and if you were designing a CRM type system, you wouldn't design a CRM for the hospital. You would, it needs to be patient based, not service based.
Absolutely.
Thanks, Matthew. That's another way of looking at it.
I love the term safety net, and I think that's absolutely key. You know, we need that clarity, and we need our medical professionals and nursing professionals to feel that they are not entirely responsible, that there is, when the patient leaves hospital, there is another system. It's almost like passing that baton on to the next person, isn't it? You know, we do our very best in the moment, and we try our very hardest, but actually, you know, there are other people who are going to sort of pick up that baton and run with it to care for those patients when they're out of our building.
Thanks, Victoria. Can I bring Helen in at this point then, and ask Helen what her views are then about sort of replacing a typical ward round with CRM? What are your thoughts, Helen? What do you think?
Well, it was really interesting listening to Matthew, and I'm really pleased that he's being a bit provocative, and it struck a chord with me a lot. So I did 10 years full time in Cheltenham looking after an elderly care ward and hip fractures. But for the last 4 years, I've worked half in the community and half in the hospital. But my hospital work now is front door, so it's in the ED or it's on our short stay unit for frail older people. And there's 2 consultants on every day, and I'm currently partnered with an ED consultant. And it's really refreshing working with her, and she does demand everything immediately. If she wants an X-ray or a CT, she just gets on the phone like she would in ED and expects it done, and it's fabulous. There's just so many things going through my head. But working out in the community, so for 4 years, that's definitely opened my eyes, and we certainly need disruptive thinking in terms of looking at the whole system. And I think I've got a colleague similar to me. We're joint appointments from the acute hospital and the community trust. We need much more of those, because however well you're informed about your community colleagues, it's just not the same as working with them and going to see a patient with them. And the community matrons I work with, they're all independent practitioners. They can manage complex elderly extremely well on their own without my input. They're prescribers, and then I can give them support on the complex ones. So yeah, that would be my key thing, is the integration has really got to go at a pace. And I think you could do it with joint appointments, or we could just do it by rotating staff. You could make it part of the mandatory training. Every 6 months we all go and shadow someone for 6 months in a totally different role.
I think it's really interesting, and I've worked out who that individual is you're talking about, but you know, and of course the learning I've observed her in the ED, but the learning she brings back from the elderly care to the ED. I made myself slightly unpopular at the RCP about 3 years ago, when I made the suggestion that we ought to get rid of specialties because they were wrong. Because the specialties were designed back when the NHS started, when people had one condition. And how often do we all see people with one illness? And there's very few specialties who deal with more than one organ. Geriatricians are an exception to that. Paediatricians are, and of course I would say emergency physicians are. But so often, people have got their diabetes that's affecting their kidneys and their heart, and they're seeing 3 different consultants for it. And one of the suggestions I was making is, shouldn't we be training people who can look after these common groupings? We've done it for the elderly. Why don't we do it for common groupings that occur in other age groups? But I'd agree with you. As a step to that, just learning and sharing together. And I think it's fascinating to see people who are officially in the same roles in community and hospital. I think from what you're saying matches my experience, is the level of responsibility that the community staff are allowed to take at the same grade in the same profession is much, much greater than in hospital. And I don't know how we've developed that.
I think that's really true. I have to say, now when I look at the wards, I think, gosh, it's so old-fashioned.
So Matthew, I'm going to come in and thank you, Helen. Unfortunately, Claire's just messaged me to say that she's been ejected from the room, which none of us on the call should take as feedback of Claire's ability to chair. So having hogged all the conversation at the beginning, I'm now back in the chair. So Matthew, I mean, just to comment, and with a bias that I am a specialist who used to be a generalist. I guess the college has acknowledged, as has Health Education England, the challenges and the need for more generalists, but also at a time when, as a specialist, things have never been more complicated. The drugs that we use, the treatment options, all those kind of things, even in my short career, has expanded beyond belief. I can barely pronounce some of the drugs I'm expected to prescribe nowadays. So I don't quite know how we balance that internally. And then when we talk about systems, we still have these archaic artificial boundaries between hospitals, primary care, community care, etc., you name it. So any thoughts about how, or what industries have learned from, which industries have learned to break those down and change those things?
Well, of course, I can tell you the solution, because we know that integrated care systems are going to solve all of that. So the 1st of April, it will be absolutely fine. Now, I think if you look at, I mean, I've done quite a lot with retail sector, and the biggest single thing they did was they started looking at the customer's journey, not their departments. So the way they design the stores physically is they worked out what are the groupings of products that people buy, and then there's a careful balance for them, of course, because you would think they'd go, well, we'll put those grouping of things together, but what they also then work out is what are the things you might buy if you walk past them. So they know the 3 things you will buy, and they intersperse those with the things you might buy if you walk past them. So they've balanced that, improved the patient journey, but also improved their sales. But it's an illustration of the user journey is at the centre, but the business is still there. How do we base it around? Our patient comes to the hospital and has as few contacts as possible. They go to one clinic, not 3 different clinics in that example I gave earlier. For the ward round, how many people do they need to see? To be really, I said at the College of Physicians, I suggested getting rid of specialties. Should we get rid of professions? Should we create new professionals who can do as much as possible for the patient, rather than having, the OT, the physio, the nurse, the doctor, all doing their little bit. Could we create one professional who could do it all?
Well, I think Matthew, on that point, exactly. I think within the collaborative, and I don't know if people want to share some ideas on this or their feelings in the chat room, but I do know that a number of the sites we're working with who are part of the collaborative are pretty innovative in their workforce. So they do use competency-based working over and above professional silos. Ironically, that I guess that's disruption, possibly out of forced disruption, if you see what I mean. We looking at workforce a lot at the moment, and we, from the Royal College this week, 48% of substantive consultant posts in medical specialties are vacant at the moment. So there is a disruption, a need for disruption, whether we like it or not.
Anytime we talk about disruption, we immediately talk about, all our lives have been disrupted professionally and personally during the pandemic. Last night, when the speakers were getting ready for the patient safety conference, it was really interesting, the physicians on the call, the disruption of having to wear scrubs rather than their suits. But actually, they were all going to stay wearing scrubs. And they said there's no way they would have moved into scrubs if it hadn't been for a pandemic. Were ward rounds, is people's experience, were ward rounds done differently during the pandemic? Is there anything to learn? Because it's been one of the biggest disruptions to healthcare. Or have you all carried on doing it the same?
Well, if I can invite people to put their hands up. So from a personal perspective, I think we adapted really well to and responded well from a continuity perspective. So we took the ED kind of model, as it were, and just broke everyone down into cells and worked in blocks. So there was always overlapping. So the consultant would work with 2 junior teams and provide 7-day cover, but the juniors would provide 3- and 4-day cover. But there would always be consistency over that time period on the wards. So we kind of, but of course, the challenge there, Matthew, was that during COVID, the hours and the working time directives and all those kind of things slightly went out of the window, and we paid our workforce over and above. And arguably, that's one of the reasons why they're tired now, arguably. And
I guess, with any disruption, there's some disruption, like wearing scrubs, that's just easily sustainable. There's not much extra resource apart from some laundry bills. As you say, there's then those changes back to working groups. You could call them perhaps firms or something like that. It has consequences that aren't sustainable, but they tell us what might be better for the future, and how can we work towards them.
Well, thank you. I just wonder, David, if you're still on the call, I wonder whether there was any examples or any thoughts you had from an allied healthcare professional perspective and pharmacy in particular around that.
Nothing immediately springs to mind, to be honest.
That was not the answer I was hoping for, Dave.
I'm not normally shy in coming forward, but I know when to keep your mouth shut when I've not got anything to say.
A wise man. So I should take a leaf out of your book then. Can I bring in then Claire and or Wendy on who? There's been an interesting discussion going on about 24-hour care, and of course I'm very London centric, so I can get just about whatever I want 24/7 by just walking to the top of my street, which makes me quite lazy. But also I notice in metropolitan areas that is definitely how we approach healthcare. So Wendy and Claire, there's been some discussions about 24-hour community care. I don't know if both Wendy, your camera's on. Do you want to start and then Claire join?
It's a really interesting debate, actually. I provided 24-hour nursing care in the community in my early days as community nurse, and it's a very difficult thing to deliver when you're talking about delivering care in people's homes, because one of the things is the provision of care. It depends what care is needed. I've changed people's sheets. I've put the dogs out for a walk. I've done all sorts. But actually, when somebody needs care overnight and actually it can't be left till the morning, say 8 AM. We're talking about IV infusions. We're talking about medication not needs to be acutely given. So it's a really difficult balance of provision in the community being at the right level for home-based care and using our acute settings for the right level of care for patients. But as Claire Old and I have had a little debate around, there are 24-hour community services. GPs are available 24 hours a day, but as Claire says, that it's the so what element of that. Yes, somebody's got a chest infection. Yes, somebody's got an UTI at 2 o'clock in the morning. What do we now do? And that's when it does start to get very difficult in the community.
Thanks, Wendy. Claire, would you like to come in on that?
Yeah, so that's absolutely right. I was just trying to be disruptive, as in trying to think about the things that would stop people coming home from hospital in terms of length of stay being reduced. And of course, we're all aware, aren't we, of the challenges in health and social care at the moment in the community and the domiciliary care agencies, etc. But when our hospital colleagues hear of that, then that risk taking goes down, I think, in terms of, well, I'm just not sure whether this lady can cope overnight, and therefore we'll just keep her in for another few days, which turns out to be a few weeks often, as the patient deconditions in the hospital bed, and then we have to deal with the deconditioning. So realistically, what we need to do is to think about the integrated services, as Matthew says, but we need to think about 24-hour care and how we can assure the band 5 nurse who is discharging a patient that we do have the services in the community where we do, but actually we recognise that we don't have in some of the rural areas that I live in, Andrew. You don't have that 24-hour care, and we heard, didn't we, about asking relatives, but we have a lot of nuclear families where relatives live an awful long way away, and that's why it's important that every patient is dealt with in a different way. So yeah, I just think we've just got to just think about how we provide services in the community maybe differently as well. And I know this is about ward rounds and the ward round collaborative, but it's about how we can get people home from the ward rounds, and that's about risk taking. But we need to ensure that everybody understands what risks they're taking.
So for me, the danger here is speaking about anything to do with community when the 2 previous people have taught me a lot about what I know about community. But the place I'm working in at the moment within the ED and the acute medical wards, one of the problems is they don't know what's available in the community. So their perception is it's too high a risk to send them home because they don't realise. And if I go back to what would other sectors do CRM wise, you would have a really good thing that they would call a directory of services, but it would be completely different from what the NHS would call directory of services, as in, first of all, it's live, so you look at it and it tells you what is available at this minute, but it doesn't just tell you there is a service available, the community nurse could go in and do this. It actually says, and there is an individual available to do this at 3 o'clock in the morning. So you actually then book it straight in to that individual. So it takes it all the way through, rather than, well, go home and ring the community nursing services and ask them to come and see you, and all that doubt behind it. Doubt on the patient side, doubt on the hospital staff side. They know with absolute certainty they have booked an individual who will be there. The NHS doesn't seem able to do that across boundaries. And again, that same word keeps coming up. Is it about trust? Do the community services not trust the hospital to not overload them, to not book in the system? And it's interesting, again, the places where I've seen it work is often because it's one organisation. So you haven't got, you've got one barrier removed of the inter-organisational trust.
Thank you, Matthew. I'm going to wrap this up. I suspect you can appreciate people like me and Matthew could chatter like this for days on end. but time has run out on us. I just think it's been a fascinating presentation, Matthew, and really thought-provoking, as I knew it would be. As is often the case with these clinical learning events, it feels like the start of something rather than the end of something, and I really like the way that we've tried to integrate the business of what we do on a ward, i.e. a ward round, with the patient journey and the patient experience within a healthcare system and a care system, and highlighting the complexities, but at the same time recognizing how we could where the challenges are and potentially what we need to improve on things. Unfortunately, I was dying to ask whether we were going to get a ward round, such like the new Amazon shops that have just opened in London, where you don't need any money. They scan you in, they can tell what you've taken off the shelf, and it comes out of your Amazon account before you get home. I don't think we'll ever get to that in healthcare, not in the short term, but there's food for thought anyway. Just a couple of closing remarks. I'd just like to thank Matthew for presenting today. It's always great to hear you talk, Matthew. Thank you very much. It's brilliant.
Thank you for inviting me.
Our pleasure. Watch for the next invite, Matthew. Thank you everyone for joining the event today. I really appreciate just how much pressure people are under from a workforce perspective and a clinical perspective, so we really value your attendance. We would also really value any feedback that you may be able to offer us. Again, Crystal will send around some evaluation forms with a certificate. This is available to watch on demand, so we'll post that and circulate it, and please encourage people to watch and just have a think of how you can affect change locally. Our next event is on Monday lunchtime, where Vince is in conversation with Becky about her journey in QI and sustaining QI. It'll be a great event, and we really look forward to seeing everyone on our final event of the collaborative on the 16th of December for our final sharing and learning event. Just say thank you all once again for your time today. Continue the great work that you're doing, and have a good afternoon. We'll see you again on Monday, hopefully, if not before. Bye now.